Bartonella buddies, I'm calling this look Hot Cheetos Glam. I've been reluctant to make this video for many reasons. There isn't a lot of research behind it. It's a very important topic. And when I have expressed to people online what I think is the best way to treat Bartonellosis, some people have been salty to me. As many of you know, I have not been able to treat the Bartonellosis due to very severe MCAS. I've been working on this relentlessly and systematically for 2 long years along with my 5 expert doctors. That being said, this video is going to be a long one, so I'm going to put timestamps in the video description box below and along the bottom bar so you can follow along with each chapter. I do this backwards from right to left so that you don't have to. I'm going to start this video off with the protocol that I intend to take for Bartonella once the MCAS is better controlled. You don't have to follow this protocol. I'm not your mom, I'm not your doctor, I'm not a doctor at all, and even if I was your doctor and your mom, I still wouldn't be able to make you do this protocol unless you were a small child. Also, since I am talking about very specific treatment protocols, including dosages, I want to make it very clear that this is not medical advice. I will then explain to you why this is the protocol that I intend on taking and give you my limited anecdotal experience with this protocol. I will then go into some frequently asked questions and critiques that I see pop up all the time in our Breaking Down Bartonella informational support group on Facebook. So let's start with the basics of the antibiotic protocol. Before I go any further, I want to point out that this is just the basics of the antibiotic protocol, and you can think of this as the meat and potatoes, or the foundation, or the skeleton, or whatever metaphor you like. Every protocol for Bartonellosis must take into account an individual's drug allergies, comorbidities, genetics or epigenetics, and involve supportive therapies like support for the adrenals and probiotics. The antibiotic protocol that I intend on following involves Clarithromycin, Rifampin, and Rifabutin. This protocol is often referred to as Dr. M or Dr. Moziani's protocol. And I want to make it clear that I am not speaking for Dr. Moziani in this video or ever. If I make any mistakes when talking about this protocol, those are solely my mistakes. If you want to hear about this protocol from the horse's mouth, I will put the link to the webinar in the video description box. If you have Bartonellosis and you haven't watched this webinar, I don't know how to say this politely, go freaking watch it! In this protocol, the clarithromycin is started first, and it is slowly titrated up to 500 milligrams twice a day. This titration period will depend on how one tolerates the clarithromycin, but it's not uncommon for the titration to take 1 month or even 2 months. Once the clarithromycin is at full dosage, then the rifampin is added, and this is also slowly titrated up based on the tolerance of the individual until one reaches the full dosage of 300 milligrams twice a day. This titration might look like 150 milligrams in the morning for 1 week. During week 2, one might add 150 milligrams at the evening dose, and so on and so forth. However, some people might titrate up more slowly in order to mitigate what is known as herxing. If you've been diagnosed with Bartonellosis, you're probably familiar with the term herxing. This is lingo for a Jarisch-Herxheimer reaction. When I first heard of a herx, I thought it was bullshit because I am a natural-born skeptical biatch. But a Jarisch-Herxheimer reaction is definitely a thing, and it was first observed by Dr. Jarisch and Dr. Herxheimer when treating syphilis patients with mercury. Do you want syphilis or mercury poisoning? Take your pick. These inflammatory reactions are, in general, poorly understood, but have been observed in the treatment of Lyme disease, Bartonellosis, and brucellosis. Herxes can manifest with symptoms such as fever, malaise, headaches, flushing, anxiety, and an exacerbation of an individual's current symptoms. At any time during antibiotic therapy, a person can experience a herx reaction, and so this is why those meds are slowly titrated up. Back to the protocol. Once the patient reaches full dosage of clarithromycin and rifampin, the patient stays there for several months. How many months exactly? Well, that depends on the individual, but I would say anywhere from 4 to 6 months, give or take. Then, the rifampin is switched out for rifabutin. Rifampin and rifabutin are from the same class of drugs called rifamycins, but they have key differences, with the main one being that rifabutin penetrates tissue much better than rifampin does. I previously did an interview with Amy and her son Jack, who was very sick with Bartonellosis, who is now symptomless after treating with Dr. M. And so since they have been through this entire protocol, I will refer to their experiences throughout this video, but if you want to watch their interview, I'll put that in the video description box as well. Why did I choose this protocol? There have been no randomized, placebo-controlled clinical trials on the chronic manifestations of Bartonellosis, and these types of studies are the gold standard for developing treatment protocols. The only information we have to go off of now is the clinical experience of Bartonella literate medical doctors, or BLMDs. Different doctors and patients have different opinions on what constitutes the best protocol for Bartonella.
It's like Barbarella.
Bartonella, Umbrella, Coachella, Bella, Indelible, Goodfella,
Rubella.
Hella
Rubella.
Cruella. Well, back to the video. Different doctors and different...
I can smell ya.
I should quell ya. Different doctors and different patients have differing opinions on what are the best antibiotics for Bartonellosis and what is the adequate duration of treatment. So why do I have so much faith in this protocol? Let me count the ways. Number 1. Dr. M is considered by many to be the Bartonellosis expert. If you look at the case reports and literature that I cite in my videos of people very sick with rheumatological, psychiatric, and/or neurological manifestations of Bartonellosis, which MD's name is often on those papers? Dr. Mosiani's. He is also the Chief Medical Officer of Galaxy Diagnostics, which is the lab that publishes extensively on Bartonella and is led by our Bartonella whisperer, Dr. Breitschwert. At the filming of this video, Dr. Mosiani is also the president of iLads, and I think he has done a very good job of prioritizing good research and sound science during his time in leadership there. Number 2. I have a local Bartonella literate medical doctor, and he was the first one to diagnose me with Bartonellosis. He, unlike most doctors who treat Bartonellosis, doesn't run in the iLab circle. He is a board-certified rheumatologist, and he has a PhD in immunology. Once again, I'm not speaking for him, but I know that he treats Bartonellosis with antibiotics and/or herbs. For me specifically, we have discussed using Clarithromycin, Rifampin, and Rifabutin. So I think it's pretty telling that these two Bartonella experts, who don't have a professional working relationship or really any relationship at all as far as I'm aware, have come to the same conclusion that for me, I should be on Clarithromycin, Rifampin, and then Rifabutin. Now to be clear, this is not what my local doctor uses for all of his patients. And the third reason I intend on doing this protocol is my experience with these antibiotics. Throughout my 2 years of being disabled, I have tried azithromycin, clarithromycin, and rifampin, but I had to stop all of them due to increasing MCAS reactivity. But keep in mind, I have increasing reactivity to herbs, supplements, so it's not just antibiotics. So first, I was on 150 milligrams of rifampin once a day for 7 weeks before I had to stop due to increasing MCAS reactivity. I don't need any lectures on being on it as a monotherapy or stopping rifampin. So once my MCAS calmed down over the course of a week, I had a decrease in pain and reactivity that allowed me to come off my Valium, off my H1, off my H2 blockers, and it allowed me to start my YouTube channel. And that decrease in pain and reactivity was the last bit of evidence that I needed to 100% convince this natural-born skeptical biatch that I indeed was suffering from a freaking cat bacteria and my doctor wasn't a raging lunatic. I held on to this decreased pain and reactivity for about a month before, unfortunately, backsliding down to baseline. So next, I took clarithromycin, and I experienced 2 small herxes that each manifested with low-grade fever, fatigue, malaise, and chills. I experienced these herxes after being on only 125 milligrams once a day for 10 days, but I unfortunately had to stop due to increasing relentless, painful, excruciating belching from MCAS for 10 hours straight. I did feel slightly less pain before the MCAS stopped me in my tracks. Is this because I'm a fast responder, or is it because many antibiotics, including clarithromycin, have anti-inflammatory properties outside of their antimicrobial properties? Or both? I would argue that since I experienced those 2 small herxes, that the lessened pain was due in part to killing some Bartonella, but obviously I have no way to prove that. Now let's compare my experience with clarithromycin to my experience with azithromycin. And as you can tell by their similar sounding names, they are from the same class of antibiotics called macrolides. For 5 months, I received IV azithromycin at my doctor's office because I was too reactive to take antibiotics by mouth. I didn't get a pick or a port, just a fresh poke each day. Each day, I would be pre-medicated with IV Benadryl, and on Monday, Wednesday, and Friday, I would be pre-medicated with a low dose of an IV steroid, and on Tuesday and Thursday, I would be pre-medicated with IV Toradol, which is an NSAID. Unfortunately, I experienced no improvement during these 5 months, even though I was on a much higher relative dose of azithromycin than I was for clarithromycin and a much longer period of time. For reference, 300 milligrams of azithromycin is 3/5 of the usual daily dosage, and 125 milligrams of clarithromycin is 1/8 of the daily dosage, and 3/5 is larger than 1/8, and that's math. So I never herxed on 3/5 of a daily dosage of azithromycin for 5 months, but I did herx in only 10 days of only 1/8 of the daily dosage of clarithromycin. So this third reason of why I intend on taking clarithromycin, rifampin, and rifabutin is because of my own anecdotal experience of clarithromycin being more effective than azithromycin and my own anecdotal experience of rifampin being helpful. But I am well aware, and you should be too, that anecdotal experience is not science. So now I'd like to go into some common questions and critiques of this protocol. Why use clarithromycin over azithromycin? Honestly, I couldn't find any studies comparing the effectiveness of clarithromycin to azithromycin, even in vitro, for any Bartonella species at all. So if you find one, please send it to me. Dr. Breitschwer, our Bartonella whisperer, stopped using azithromycin in treating animals long ago after he published a paper in which 6 Bartonella hens lay strains rapidly developed resistance to azithromycin. They did not compare it to clarithromycin, but this evidently was enough to scare him off using azithromycin altogether. He has told me that he was concerned that using azithromycin in a pet could breed a resistant strain in that pet, which then could be passed on to the pet's owner or a veterinary worker. Dr. Mosiani learned about treating Bartonellosis in humans from Dr. Breitschwer's experience in treating Bartonellosis in animals. And this is very smart and interesting because humans are animals. Dr. Mosiani likes to use clarithromycin over azithromycin for several reasons. In his webinar, he explains that clarithromycin is thought to inhibit endothelial cell proliferation. Say that 3 times fast.
Me?
Yeah.
Endothelial cell proliferation. Endothelial cell proliferation.
Endothelial cell proliferation, endothelial cell proliferation, endothelial cell proliferation.
Wow. Endothelial cell
You should see our face.
Endothelial
Cell proliferation. Endothelial cell proliferation. In layperson's terms, the clarithromycin basically prevents the Bartonella from... My shower's peeing. Can you hear that? Okay, it stopped. Oh, dribbling. My shower's incontinent. In layperson's terms, the clarithromycin basically prevents the Bartonella from developing homes in areas that it shouldn't be. The clarithromycin's like, do you have a permit? Also, in my conversations with Dr. M, he discusses how clarithromycin in general is mast cell stabilizing, whereas azithromycin in general is mast cell activating. Perhaps one of the most important reasons he uses clarithromycin is because clarithromycin inhibits a certain enzymatic pathway called CYP3A4. CYP3A4 is also involved in the metabolism of many hormones, including cortisol, estrogen, and testosterone. With regard to cortisol, according to Dr. Mosiani, many chronically ill patients develop a condition known as adrenal fatigue, which is a diagnosis that is not accepted by mainstream medicine. So without getting sidetracked by that whole controversy, Dr. Mosiani states that he likes to start with clarithromycin because it inhibits this pathway, which then means that hormones like cortisol are not metabolized and excreted from the body as quickly, which means that cortisol levels go up and the patients can feel better because of this. So the next question or critique of this protocol is, what about the interactions between clarithromycin and the rifamycins? To understand these interactions, let's go into the CYP3A4 enzyme a bit more. The CYP3A4 enzyme is underneath a larger umbrella of enzymes called CYP450, which stands for cytochrome P450. Umbrella. Bartonella umbrella. You can stand under my Bartonella, Ella, Ella, A. You can stand under my Bartonella, Ella. Baby, it's raining, raining. Ooh, baby, it's raining, raining. I sound just like Rihanna. Up to 90% of all pharmaceuticals are metabolized through the enzymatic pathways underneath this umbrella. Rifampin is one of the strongest inducers of the CYP3A4 enzyme, and this enzyme is not only involved in the metabolism of cortisol, but also 50% of all prescription drugs. Let's first look at the interactions between clarithromycin and rifampin, and then we can look at the interactions between clarithromycin and rifabutin. We know that clarithromycin inhibits this pathway. What are these hands? What are these hands?
The pathway.
We know that clarithromycin inhibits this pathway, while rifampin has the opposite effect of inducing this pathway, which means that when you take it, you will metabolize and excrete more quickly cortisol, estrogen, testosterone. I can attest to this. When I was on only 150 milligrams of rifampin once a day and a hormonal birth control, I actually started to break through bleed because of the decreased estrogen. Studies have shown that rifampin can reduce the serum levels of clarithromycin. However, the serum levels of clarithromycin aren't that important given that clarithromycin accumulates to a large degree in tissues and macrophages, which is a type of white blood cell. Now let's talk about the interactions that have been reported between clarithromycin and rifabutin. Rifabutin induces the CYP3A4 enzyme, but to a much less strong degree than rifampin. This means when the clarithromycin is given with the rifabutin, the clarithromycin inhibits the pathway, which means that it can increase the levels of the rifabutin. As you can imagine, higher levels of almost any medicine means a greater risk of toxicity and side effects. The main complications that are reported in the literature and that Dr. Moziani has seen include decreased white blood cell counts, which is called neutropenia, raised liver enzymes, and uveitis. In his webinar, Dr. Moziani talks about the mild to moderate neutropenia, and this neutropenia usually occurs at the same time as the liver enzymes rise, specifically AST and ALT. Elevated levels of these liver enzymes may indicate liver damage, but instead, Dr. M hypothesizes that this is due to Bartonella being killed in and around various types of liver cells. How did he come to this hypothesis? Well, Dr. Moziani used to take his patients off the antibiotic therapy when he saw the neutropenia and when he saw the elevated liver enzymes. But through his years of practice, he realized that when he kept patients on the antibiotics, these things were transient, meaning that they would come and go. He says that he has had no adverse consequences in his years of doing this. I can't tell you what levels of neutropenia or enzymes are safe to push through because I'm not a doctor and this isn't medical advice. Oh, what a litigious society we live in. But if your physician is wanting to stop antibiotic therapy due to these phenomena, I suggest that you have your physician listen to this specific portion of the webinar. According to the scientific literature, anywhere from 8% to 38% of people taking both clarithromycin and rifabutin develop uveitis. Uveitis is the inflammation of the uvea, which is the inner portion of the eye wall, and it can manifest with redness of the eye, pain, floaters, vision changes, and it's pretty serious. Uveitis must be managed by an ophthalmologist, and it's recommended that patients undergoing clarithromycin and rifabutin therapy, before they start that, get a baseline eye exam from an ophthalmologist. If and when uveitis develops, an ophthalmologist can prescribe steroid drops and drops to dilate the eye, and this usually resolves the uveitis without stopping the antibiotic therapy. Please note that steroid eye drops are not like systemic steroids at all. The uveitis is hypothesized to be an eye herx, and this phenomena has actually been reported in the scientific literature. In my interview with Amy and Jack, they discussed Jack's experience with uveitis and how it was managed throughout therapy. Despite these side effects, clarithromycin and rifabutin are actually prescribed in combination often for the treatment of MAC, which stands for Mycobacterium avium complex, which is a type of opportunistic infection that can affect immunocompetent people, but more so immunocompromised people. MAC is an infection of the lungs, and patients with MAC are often on this combination therapy for up to 12 months and maybe sometimes longer. Why is low-dose hydrocortisone often prescribed when treating with rifampin? Aren't steroids bad to use when treating chronic infections? I'm not going to lie. This is one of my pet peeves when I see people online telling other people online to never use steroids. First, I want to say that there are almost never absolutes in medicine. See what I did there with that sentence? I didn't say that there were never absolutes in medicine because that would have been an absolute. I said there are almost never any absolutes in medicine. I'm not saying that steroids are fun drugs to take, and I'm well aware of their scary side effects. However, steroids are sometimes necessary when dealing with these chronic infections. An example would be a very severe mast cell activation patient. With regard to rifampin, most patients on this protocol are given supplemental hydrocortisone. Hydrocortisone is the synthetic preparation of cortisol, which is what your body naturally makes, as opposed to other steroids, which have different chemical structures and potencies. This supplemental hydrocortisone is given to replace the cortisol that is excreted in excess due to the rifampin and the CYP3A4 pathway that we discussed earlier in this video. According to Dr. Mozziani, if the physician doesn't account for this effect of rifampin, the patient can become very sick and the treatment can backfire. He also says that if patients are on hormone replacement therapy, the dosages of that replacement therapy might have to be doubled, tripled, or even quadrupled. How and when should I take my antibiotics? Obviously, this isn't medical advice. How many times do I have to say that before I feel like I've adequately covered my own ass? And once again, I'm not speaking for Dr. M, but I have learned from Jack and Amy's experience that Jack was instructed to take his rifamycin 30 minutes before a meal, eat the meal, and then take the clarithromycin. In Dr. Mozziani's experience, this is the optimal dosing schedule in order to capitalize on the synergy of these two antibiotics. Why not use doxycycline or other antibiotics? Dr. Mozziani says in his webinar that the conventional protocol of doxycycline and rifampin doesn't really seem to work, and he has learned this from Dr. Breitschwert's experience in animals. Does this mean that doxycycline has absolutely no action against Bartonella whatsoever? No. Most antibiotics are broad spectrum and kill lots of microbes. But when I asked my other BLMD what he thought about doxy for Bartonella, he was like, "Puh. My appointments with him are only 20 minutes, so he has to convey a lot of meaning quickly." Dr. M says in his webinar that doxycycline might be a good place to start because then the patient will experience less herxing because it's less strong. And he's also said this to me in my conversations with him about azithromycin as well. Some doctors use Bactrim, and Jack's diffuse bone marrow inflammation cleared up with the use of clindamycin. Fluoroquinolones are a class of antibiotics that are effective against Bartonella, but their toxicities make them unattractive for use in humans. So another criticism I occasionally see is that this protocol is too aggressive and too long. All I want for Christmas is a teleprompter.
Depends whether you've been naughty or nice.
What have I been?
What moment is it?
You're not Santa.
Ho.
You are a hoe.
Okay. Unusable. Go.
Why is it unusable?
That's stupid.
You really surprised me there. I thought you were going to say because it's like risque. You're right, it's very dumb. For people with severe disease manifestations of Bartonellosis, like Jack or me, I feel like the potential benefits outweigh the potential risks. Oftentimes, the aggressiveness of treatment reflects how sick someone is, and the aggressiveness of their blush reflects how aggressive of a person they are. With regard to length, 6 months to several years is a long time to be on antibiotics, but it's not unprecedented. With tuberculosis, it's not uncommon for people to be on antibiotics for 6 months or up to 2 years. People are on systemic antibiotics for years for acne, and I already talked about how long people are on antibiotics for the treatment of MAC. I've also seen far too many people get anywhere from 90 to 100% better and then stop the antibiotics too soon or without doing the rifabutin portion of therapy, only to relapse around a month later, sometimes with very serious symptoms like seizures. It is my opinion that you want to do it right the first time if you can. If this protocol seems too aggressive for you, that's fine. You do you, boo. I'ma do me. There are more questions and critiques that I plan on addressing in a future video, like can Bartonella be eradicated from the body? Can antibiotics be pulsed? What happens if your Bartonella becomes resistant to rifampin, etc.? And I'm going to address those in a future video, so make sure you hit that subscribe button so you're notified when I release that video. Also, don't forget to give this video a thumbs up if you found any of it informational or helpful. Any of it, my voice cracked.
Did.
Piper says, Jake, do you know what was missing from your things that rhyme with Bartonella? No, what, Piper? Stella. Oh, you mean like the beer, Stella Artois? No, I mean like... Stella! Bye, Bartonella buddies! This seems raunchy for back then.
Tennessee Williams.
Wow. Oh, he drops to his knees. Oh, his face is right in her crotch. Now she's rubbing her hands down his back. He's got a nice back. What did he do? That's the question.
Bad?
Yeah.
I don't remember.
What did he do? You don't grovel for nothing.